Thank you all, the organizers, for inviting me to come here. And first I want to show a video from last year, because unfortunately I couldn't enter India. That was with my American colleague at the Chennai airport, when we were told that we should take, or we have to take, the same plane back home. So I was lucky this year that it was without any problems to enter here. So now I come to my talk. So endovascular repair of aortic disease was first described 22 years from now. And they reported their experience in 13 patients with thoracoabdominal aortic aneurysm. And what they did, they had for each patient a custom designed stent. So you see here that stent, that metal thing, and then it was this woven curtain around that, and for each patient it was really customized. That is not longer the reality right now. Now we have a lot of different stents available to treat that for short distance, long distance. And what we know from a meta-analysis published by David Cheng, 2010, where they compared endovascular versus surgical repair, is that the endovascular repair in terms of paraplegia is superior to the surgical approach. I think this is really one of the most important things, and I will address that issue further on in my talk. And in stroke, it's a little bit favored to surgical repairs. And if you look at the clinical outcomes, there is no significant difference between 30-day death, 1 year, 2 to 3 year stroke, but the overall complications are less in the endovascular aortic repair. If you look at these deaths in some subgroups, it favors, but as I mentioned before, it was not significant difference. The same as 1 year, and as longer the follow-up is, the more both techniques come together in terms of outcome. So that reflects the very severity disease of these patients. So that means no matter if you do surgical or endovascular repair, you will have at the long-term follow-up, of course, high mortality. This is the most recent, because I should talk about the new aspects, the most recent review of the outcome, which clearly shows that is a single-center study from Germany, where they included 269 patients and end up with 100 aneurysm patients with different indications, all the other one. And they had more or less the same mortality in hospital. 40% 30 days mortality, 17% hospital death, so that's quite a lot. 40% complications, where you have these endovascular leakage type 1 and type 3. These are the endovascular leakage types you should address during your hospital stay. And what does that mean for those who are not so familiar with that? So the type 1 is a gap between the graft and the vessel wall at the seal zones of that stent. Here you see a picture with the stent, and here you have this endoleak type 1. For this endoleak type 1, there is really a risk of aneurysm sac enlargement and further on rupture, so you should address that. And the second one is the type 3 of all these type 5s, because all the others are not clinical important. So type 3 is a defect or a misalignment between the components of the endografts. That is shown here. That is shown here. Thank you very much. So, and they report their 5 years of survival, and you see after 5 years, only half of the patients are still alive. So we are dealing really with a high-risk population, and the treatment is not good if you look at the 5 years outcome. It's better if you see that you just operate on those who are elective. So then you will end up of around 70%, compared to the urgent cases where you have a very high mortality, 70% after 5 years. So first thing is, hopefully, if you do a TEVAR, then you should do it on an elective base. And with the TEVAR, the spinal cord ischemia is still a little problem. Not so much as compared to the conventional surgical one. And there are some new things out. And this is a meta-analysis published last year, which clearly shows in these patients that you should use a lumbar drainage for protection of the spinal cord. May I just ask the audience who would use regularly spinal cord lumbar drainage in those patients? Just you? Who deals with those patients? So when you don't use regular the lumbar? Not regular. So of course it depends on the extent, but whenever it's a high-risk patient, if you have a large distance to cover with the stents, you should think about that, because that is really in that meta-analysis that you should use that. And that is also stated in the position statement published 2 years ago, where one of our cardiac surgeons was the first author in that, where, of course, you have different mechanisms of that spinal cord ischemia in open and in TEVAR repair. And for TEVAR, it's the reduction in the proximal, the medial, and the distal direct and collateral arterial blood flow. So you don't have a cross clamp in the TEVAR in contrast to the surgical one, but you have or may have a reduction in the flow to the spinal cord. And this reduction of flow to the spinal cord will result in an increase intracerebral and intraspinal pressure, and that means that your perfusion pressure goes down. So if you have a spinal drainage, then you can monitor that pressure, and thank you. And we aim to have a spinal pressure around 10 during the procedure. So whenever the spinal pressure increases, then we will drain lumbar spinal fluid to decrease that. So and these things are the cerebral spinal fluid drainage, that is very important, and maybe the fast track concept in those patients, and to have a really very good control about the neurological examination, because a sleeping patient is not good to control regarding neurological complications. And the risk of paraplegia, of course, is depending on the type of the aneurysm and the localization. So that means this is a very low risk pathology, of course, whereas this is the highest risk. So starting right underneath the subclavian arteria and going down to the iliacal vessel, that is a high risk, even for endovascular, as you can see that here. So that means these are the patients you have to care for. And also this one here. So these, I would say, should be treated with a lumbar drainage during the procedure in order to avoid spinal ischemia. What are new concepts? So there are two new concepts which where there is not yet too much data out in clinical one. One is to use near-infrared spectroscopy to monitor the saturation. And the reason behind that is that you have a collateral circulation. And this collateral circulation is very crucial. So if this is very well defined, then you will have not so much neurological complications. That was proven in animal studies. And what we did is we used these NIRS electrodes, one in the thoracal region, one in the lumbar region. You see that here. And we tried to keep the saturation equal to the normal level. That is one concept. The other concept is that you may increase the collateral circulation by coiling segmental arteries before the procedure, weeks and months before that. Selective segmental arteries in order to increase the collateration. That means after that, if you place the stent, hopefully that the collateral circulation will be sufficient to support the spinal cord. Here again, it's drawn, so you have that collateration. And this is a major fact in if the patient develops neurological complications or not. So we should aim to increase that and to monitor that correctly. So that is how it looks like. See, that is a patient in our induction room where we place that electrodes in and where we look for the saturations. And up to now, it was just 13 patients. But you see, these are overall patients. So surgical as well as TEVA patients. And you see with the surgical that you have a drop in that lumbar saturation, whereas the thoracic saturation is more or less stable. Up to now, we don't have any thresholds how to intervene. And these are the data, and we had 3 patients included with the TEVA with no paraplegia, and they didn't show throughout the procedure any change of that NIRS thing. The other new concept, which is first published in patients with abdominal aortic aneurysm, is of course the fast track concept. That means you don't use general anesthesia, you use sedation or monitored anesthesia care in order to allow them to wake up and all that. And in this prospective study, they included these patients with abdominal, of course, and they screened that. You see that here, 114 underwent that fast track. And fast track means they were conscious during the procedure, they had no ICU stay, and they were discharged home the next day. Could you? Thank you. And they compared that with a non-fast track. And you see it's really feasible in 96% of the patients. It's good. And whenever the patient is awake, it's the same as in carotid surgery. You have a nice neurological monitoring because the patient is awake. If the patient has general anesthesia, of course, it's hard to do that. And I don't know who of you use these MEPs or SSCPs. So that is a complicated thing, and the literature, because I don't go into that for the sake of time, the literature is not convincing if it really helps to prevent paraplegia, all these things. Awake patient, you know exactly when something happens if he has neurological complications. So when this is a most recent paper published this year from a very aggressive German group where they did endovascular repair in type A dissections. You see that here. Maybe I have it here. So patients treated endovascular with that stent. You see that here, 3 stents in the type A dissection. So ascending aorta. Of course, they had only limited experience, but all these 13 patients were treated successfully in the ascending aorta. And the central message was that, of course, thoracic endovascular aortic repair in type A dissection is feasible in selected patients. Selected patients in this study means that these patients were not suitable for surgery. So, we treat type A dissections together with the surgeons since decades, and we all know that if you don't treat them, they have a really high mortality of 2% per hour, of course. And so this may be another option in the future. And their perspective is really that in a subset of these patients at high risk, at high surgical risk, with a suitable anatomy, that this may be an option. So I think Dr. Nienaber, he's really a very, very experienced cardiologist, and he stands a lot of these things. So we haven't done that yet. We would transfer the patient into the OR to do the surgical repair, of course, but that is an option maybe. To come back to reality, this year there was the guidelines, the practice guidelines of the European Society of Vascular Surgery. And they stated, and you see that classification with the 2A, that of course endovascular repair should be considered, and as well as open for patients at a low to moderate risk with an aneurysm of more than 60 millimeters or larger diameter rapid aneurysm enlargement. I think this is nothing new. And you see also these recommendations 2A and 2B. So unfit for surgery, for open repair, you go to endovascular procedure, of course. With an unfavorable aortic anatomy, you can go for a branched or fenestrated endograft or a hybrid approach. And the next thing, which was also published from an Italian group, is that all these patients should be treated in high volume centers. Not only because the cardiac surgeon is very experienced, but because all the setting around that, with the monitoring, with the post-op care, is much better developed in centers who do that more than in centers who do that a few times a day. So that is also a recommendation, which is of course a 2B, but it's nice to have it here in one of the guidelines. So for me, this is one of the first recommendations who stated that, and that's fine, I think. So, and at the end, I want to invite you to come to Berlin this year to the ACTA Annual Congress, which theme is Comprehensive Cardiovascular and Cardiothoracic Care. So that means pre, intra, and post-operatively. And for those who haven't been to Berlin, I think it's a nice city. It's not comparable in size to most of the Indian cities. They are much bigger. But for German relations, it's a big city. So hopefully we'll see us in Berlin. So thank you very much.